Now we call upon Dr. Vijaya Vashi Dhanashekaran to tell about on long-term outcomes of SFIOL versus retropupillary fixated iris claw IOL implantation.
Good evening. Even in this era of refractive IOL surgeries, the ideal option to address challenging scenarios still remain unanswered. I am here to share the long-term outcomes of SFIOL versus retropupillary fixated iris claw IOL intraocular lens implantation. Sutureless SFIOL and iris claw IOL remain popular choices for the management of aphakia. There are several studies advocating in favor of each of these options, but there are very few reports in literature with long-term follow-up. The aim of the study was to analyze the long-term outcomes in terms of visual acuity and postoperative complication resurgery rate between scleral fixated intraocular lens and retropupillary fixated iris claw IOL. The study model was a retrospective single-center study, and patients who had a minimum postoperative follow-up period of 2 years were included. Eyes with subluxated or dislocated cataract, phakic lenses, and dislocated IOLs or post-surgical aphakia were included. And eyes with prior scleroconval tear were excluded from the study. For iris claw IOL, a scleral corneal tunnel was made following a thorough anterior vitrectomy. The iris claw IOL was initially placed in the anterior chamber. Then through two paracentesis fashioned 180 degrees apart, the haptics were then clawed using a spatula. Surgical PI was done for all the cases. For SFIOL, 1.5 to 2 mm two scleral incisions were fashioned 180 degrees apart, and a partial thickness scleral dissection were carried out in opposite direction. Sclerotomy was done through the center of this scleral incision. The haptic of the standard PMMA lens was grasped, and it was inserted through a 24 gauge needle, passed through the sclerotomy port and externalized. The same was repeated for the other haptic, and after ensuring adequate IOL centration, these haptics were tucked into the scleral pockets and the flaps were then closed with an absorbable suture. The IC-IOL group had 54 eyes, whereas SFIOL had 41 eyes with a mean follow-up period of 28 months. 68% of the IC-IOL group underwent primary implantation, whereas in SFIOL there is almost an equal distribution between primary, secondary, and IOLs that required decentered and eyes with dislocated IOLs. SFIOL as a primary choice was reserved predominantly for planned surgical procedure. This is a list of the ocular comorbidities. When we see the uncorrected visual acuity changes, at 1 month follow-up, SFIOL had a better UCVA, whereas at final follow-up visit, IC-IOL performed better. On seeing the BCVA change over time, we can see that the visual recovery in the IC-IOL group occurs as early as 1 month follow-up, whereas in SFIOL, the visual recovery is seen at 3 months follow-up. Here when we see the preoperative BCVA of SFIOL group was significantly better than the IC-IOL, whereas at all postoperative follow-up visit, iris claw IOL performed better. On analyzing the primary versus secondary procedure, at final follow-up, primary iris claw IOL had a better BCVA compared to secondary procedure. There was no significant change between IOP between the two SFIOL group, iris claw and SFIOL group. On seeing the complication, 20% of the eyes and iris claw IOL group had CME, which was the most common complication encountered, whereas 24.3% of cases of SFIOL had either lens tilt or decentration, and this was the most common complication noted in the SFIOL group. 4 eyes in iris claw IOL required intervention for CME, and 5 eyes with significant decentration in SFIOL were advised resurgery, and the mean time of noting decentration was 9.6 months. In our series, following an intraoperative complication, IC-IOL was the predominant IOL of choice. Both these techniques had a better postoperative BCVA, but iris claw IOL performed better. In eyes with iris claw IOL, primary implantation had a significant better BCVA at final follow-up visit. All the eyes in SFIOL which had high IOP were medically managed, whereas 2 eyes in iris claw group required YAG-PA and 1 eye required cyclodiode procedure. Rashad et al. and our study note that CME was the most common complication. Decentered and tilted IOL has been reported in multiple studies in sutureless SFIOL technique. And though this is a retrospective study, the longer follow-up but the good sample size add to the strength of the study. To conclude, both the IOL options provide significant visual recovery, hence they are effective procedure. Majority of the post-operative complications were amenable to medical management, hence it is a safe procedure. Primary iris claw IOL can be considered to avoid the need of a second surgery. SFIOL can be considered in cases of iris atrophy. Targeted haptic design specific for scleral pockets would counter chances of late decentration. Further, prospective RCTs with the single surgeon analyzing aberrometry will shed better light regarding these two options. Thank you.
Was there any OCT done previous to in these groups?
Preoperative OCT was not done, so it was a retrospective study.
Yeah, assuming that some VMT or something pre-existing, will it not confound the results? Meaning to say more of CMEs in iris claw and
group, yes, sir. So preoperative OCTs were not done, so only post-operative period the OCTs were done, sir. And when we see like there was the SFIOL group had more of pre-existing retinal pathology compared to the iris claw IOL group, sir.
Actually, when you take two groups, they should be identically similar. Yes. If one group has got pre-existing, as he has rightly pointed out, pre-existing macular pathology, then CME post-operatively doesn't mean anything.
Yes, sir. And the CME was more in common iris claw group, whereas the retinal comorbidities are more common in SFL group. One case in iris claw had a pre-existing retinal pathology, sir.
Which visco you use in for iris claw lenses?
Pardon
Which
me, sir?
viscoelastic? Which viscoelastic you use for iris claw lens?
We use this. We use a dispersive OVD, sir, for our for the all the places of these things, sir. The use of
And now we have got a iris claw with 4-point fixation, which is going to be placed in an anterior chamber instead of doing retrofixation. They are more stable, I think. Probably they can also come and give a better results than what we have now. So 4-point fixation will be to prevent iridodonosis and everything. So that's much more safer, and you have to see directly.
yes,
It's
sir.
a little blind procedure you are putting in behind the iris and doing
Iris
it,
claw, yes,
but
sir.
that should be exactly on the LTHS side.
The de-enclavations noted in the iris claw IOL were noted in the immediate post-op. The two eyes had in first POD and one eye had it in the first month, whereas SFIOL were more of late decentration, sir.
Yeah. And did you do iridotomy in these cases?
All patients
All
of iris
cases.
claw IOL had a iridectomy that were done, sir.
Right.